Good morning. This morning we're going to be talking about a topic that's very close to my heart and a topic that I don't think everybody fully understands: hypoglycemia. And if you see the picture of me there, I'm trying to depict how awful it is to have a low sugar. I don't know that I'm depicting it as well as I could be. But if you ask any type 1 diabetic or any person who's ever had a low sugar how awful it feels, they'll give you a very clear rendition. What does low sugar do? The organ that hates it the most is the brain. It is an extremely triggering thing for the brain to not have sugar to allow its metabolism to proceed. And so in turn, it has what I call a hissy fit. When we're looking at levels of hypoglycemia, if we specifically honing in on hypoglycemia, then below 7 we consider normal. Once we get below 3.9, this is hypoglycemia, and once we get below 3, this is considered severe hypoglycemia. Now, I like this little infographic, and it doesn't only pertain to persons living with diabetes, it pertains to any human on earth, and what happens at various levels of blood glucose to the brain. So between 4 and 5 in the actual body, in order to protect the brain, if you are not type 1, you will decrease your insulin secretion. Once you drop below 4, you will increase your glucagon secretion and increase your adrenaline secretion. And these are measures to make sure that the brain still gets glucose. Once you drop below 3, the brain has a hissy fit. Decreased cognition, aberrant behavior, seizures, coma, essentially brain failure. Once you drop below 1 millimole per liter, this is where you get neuronal death, brain death. So lots of physiological things get triggered at different levels of glucose in the body. And the body will essentially do anything it can to preserve and protect the brain. So broadly speaking, we're talking hypoglycemia, a level below 4. Considered clinical hypoglycemia, and alerts and alarms will be triggered if you're on a hybrid closed loop system at 3.9. Considered severe hypoglycemia below 3, and this is generally where a patient requires assistance, either by himself or herself actually taking fast-acting glucose like a glucogel or a bit of honey, or a caregiver rubbing honey into the gums of a patient who's become unconscious, or a caregiver injecting glucagon into somebody who has become unconscious due to a hypo. It is individual. Different values apply to different people. So although we have these definitions and there are many classifications, every country has its own different classification. For me, it's far more important what's happening clinically. What is happening to the individual patient in front of me? What are the sugar values that trigger this individual patient? And what are the strategies we can do to prevent that from happening? And the crux for me is that low sugar is bad for the brain. And one hypo is a hypo too many. And this is what really got me to become so passionate about continuous glucose monitoring. When you've listened to patients tell their stories of unconscious hypoglycemia, the effect that it has on them and on their loved ones, one of the most poignant stories, and I've heard this many, many times, is a type 1 diabetic who has a baby and then starts breastfeeding and becomes unconscious. It's just one too many demands on the system of a person living with type 1. However, having a hybrid closed loop system or having continuous glucose monitoring is a system that alerts one so that one can prevent the hypo from happening. It never has to happen. So it's an early detection system, much like if you're going to have a tsunami or a volcano, where you actually prevent the damage from happening to those individual people. And I find that a technology that I think no one living with type 1 should live without. The effects on the brain of low sugar. In the first instance, the more lows you have, the more unaware your body becomes, and you become almost numb to it, which is a very bad thing. Having low sugar is in itself an oxidative stressor, and this in turn exacerbates the high sugar inflammation that usually follows a low sugar, and this is what causes brain damage. So post-hypo, you've got reactive oxygen species generation and oxidative stress is pronounced. But often post-hypo, because you feel so awful, there's a compensation with a high sugar. And it's this high sugar that makes this inflammation even worse, exacerbates the inflammation. So we get what's called glycemic variability and this ping pong, a low, a high, a low, a high. And it brings us back to CGM because multiple studies have shown the benefits, particularly in terms of hypoglycemia and particularly in terms of preventing brain damage. In summary, under the conditions studied, severe hypoglycemia causes brain damage in the cortex and the regions within the hippocampus, and the extent of damage is closely correlated to the presence of seizure-like activities in non-anesthetized rats. It is concluded that in response to insulin-induced severe hypoglycemia, diabetes uniquely increases the vulnerability of specific brain areas to neuronal damage. So what distinguishes the person living with type 1 or any person injecting insulin is that they are kind of at the mercy of the insulin. And as we know, every day is different. So today, if I inject 10 units of insulin, it has an effect. Tomorrow, it could have a different effect. And one of those days in between is when your sugar could drop below 3. And unfortunately, the first organ to pay the price is the brain. So one becomes confused, dizzy, you have difficulty concentrating, you can have a seizure, you can have loss of consciousness. All of these things can knock onto cardiovascular health, one's mood, one's mental health, as well as cause hormonal abnormalities. And beyond a shadow of a doubt, impacts on daily living. So what does ChatGPT have to say? To mitigate the risk of hypoglycemia, individuals with diabetes and their healthcare providers often work together to develop personalized management plans, which may include adjustments to diet, medication dosage changes, exercise routines, and regular blood sugar monitoring. Additionally, advances in technology such as continuous glucose monitoring systems and insulin pumps and hybrid closed-loop systems have provided valuable tools for better glycemic control and reducing the incidence of hypoglycemia. So, I believe we should be protecting brains. We should be understanding the mechanisms around hypoglycemia, what it does to the brain, what it is for a type 1 person living with this, having to inject insulin, what it means for them when they have a hypo, and understanding that in 2024 we can prevent every single hypo by having CGM. So I feel quite strongly that this is a technology that shouldn't be denied. I do believe that long-term downstream costs are drastically reduced. When someone has a unconscious hypo, they generally require an ambulance, require some time in hospital, require medical intervention. That is costly. But what's more costly is the brain damage that happens for that specific individual. And we have technology to prevent it from happening. So although it seems impossible when one starts, it is possible to actually get to a place where one can do a headstand. And a headstand does clear the mind. So my plea to funders, providers, to makers of the technology is that we collaborate and find a way to enable persons living with type 1 or persons injecting insulin to have access to CGM to prevent brain damage. Have a beautiful day.